There's a good chance that right now, sitting in your medicine cabinet, there's a pill you take every single day, something your doctor prescribed, something you've trusted for years, and that pill may be quietly chipping away at your memory. This isn't a fringe theory. It's backed by research published in some of the most respected medical journals in the world, JAMA Internal Medicine, the BMJ, and studies involving hundreds of thousands of patients. What researchers found is alarming. Certain common medications are linked to a dramatically increased risk of developing dementia, sometimes by as much as 50%. Today, we're covering 9 of the most widely used medications tied to this risk. Some of them are prescriptions your doctor may have handed you without a second thought. Others are sitting on pharmacy shelves right now, sold without a prescription. Stay with us through all 9, because number 7 genuinely caught us off guard. And it might catch you off guard too. Medication 1. Diphenhydramine/Benadryl. Let's start with one that's in almost every household in America. Diphenhydramine, sold under the brand name Benadryl, is one of the most popular antihistamines ever made. Millions of people take it for allergies, colds, or just to fall asleep at night. It's inside Tylenol PM, Advil PM, and Zizquil. You can grab it off the shelf at any drugstore for about $5. Here's the problem. Diphenhydramine is a powerful anticholinergic drug. That word, anticholinergic, is going to come up repeatedly in this video, so let's break it down once and move on. Your brain runs on chemical messengers. One of the most important is called acetylcholine. It handles learning, memory, and attention. Anticholinergic drugs block acetylcholine from doing its job. In the short term, that's what makes them good at drying out sinuses or helping you feel drowsy. But when you block acetylcholine repeatedly, over months and years, something concerning begins to happen. A landmark 2015 study published in JAMA Internal Medicine followed nearly 3,500 adults aged 65 and older over 10 years. Researchers at the University of Washington found that people who took strong anticholinergic medications, including diphenhydramine, for a cumulative total of 3 or more years, had a 54% higher risk of developing dementia compared to those who took none at all. 54% is not a rounding error. Many scientists point out that this study shows association, not confirmed cause and effect. But the signal is strong enough that geriatric specialists now routinely recommend avoiding diphenhydramine in anyone over 65. The American Geriatric Society includes it on their Beers criteria, a list of medications considered potentially inappropriate for older adults. If you're using Benadryl or any PM sleep aid occasionally, the risk is likely minimal. The concern kicks in with regular long-term use. Medication 2. Oxybutynin and overactive bladder drugs. The second medication is one that tens of millions of older adults take daily, and it almost never gets discussed in this context. Oxybutynin, brand name Ditropan, is prescribed for overactive bladder. So are toltrodine, Detrol, solifenacin, Vesicare, and darafenacin, Enablex. These are extremely common medications, particularly for women over 60, and they work by relaxing the bladder muscles. They also happen to be among the strongest anticholinergic drugs prescribed today. A 2019 study out of the University of Nottingham, one of the largest of its kind, looked at 58,769 patients diagnosed with dementia and compared them against 225,574 patients without it. All were aged 55 and older. The researchers found that taking a strong anticholinergic medication every single day for 3 or more years was tied to a nearly 50% increased risk of developing dementia. Among the drug classes most strongly implicated, bladder antimuscarinics, the category that includes oxybutynin. The researchers estimated that around 10% of all new dementia cases in the UK, roughly 20,000 people every year, might be linked to anticholinergic drug exposure. That number is staggering. For anyone currently taking these bladder medications, newer options exist that have a lower likelihood of crossing the blood-brain barrier, meaning they affect the brain less. Mirabegron, Myrbetriq, is one such option. It works differently and currently does not carry the same dementia association. If you're on oxybutynin, it's worth a conversation with your doctor about whether a switch makes sense. Medication 3. Tricyclic Antidepressants. The third category involves a class of older antidepressants that were the standard of care for depression from the 1960s through the 1980s. Many older adults are still on them today. Tricyclic antidepressants, including Amitriptyline, Elavil, Nortriptyline, Pamelor, and doxepin, Silanor, are sometimes still prescribed for depression, nerve pain, migraines, and sleep problems. They're cheaper than newer alternatives, and they work for a lot of people, but they're also heavily anticholinergic. The same 2018 BMJ study that analyzed over 40,000 dementia patients found that anticholinergic antidepressants, the tricyclic class specifically, were associated with up to a 30% increase in the odds of developing dementia, even when researchers accounted for the possibility that the underlying depression itself might be an early warning sign of dementia. Amitriptyline scores a 3 on the anticholinergic cognitive burden scale, the highest possible score, indicating definite anticholinergic activity. The takeaway here is not to stop your antidepressant. Abruptly stopping antidepressants can cause serious withdrawal effects and mental health crises. The takeaway is that newer antidepressants, particularly SSRIs like sertraline or escitalopram, do not carry the same anticholinergic burden. If you've been on a tricyclic for years, your prescribing doctor may not be aware of how dramatically this research has shifted. Medication 4. Benzodiazepines. Now we move to a class of medications that is simultaneously one of the most prescribed in the world and one of the most debated: benzodiazepines. Xanax, Valium, Ativan, Klonopin. These names are practically cultural touchstones at this point. They're prescribed for anxiety, panic disorders, insomnia, and muscle spasms. In the United States alone, around 30 million adults have a prescription for a benzodiazepine at any given time. The research connecting them to dementia has been building for over a decade. A meta-analysis published in the Journal of Clinical Neurology pooled data from multiple large observational studies and found that long-term benzodiazepine users had significantly higher rates of dementia, with some analyses putting the risk increase between 40 and 84% compared to non-users. The mechanism here is slightly different from the anticholinergic drugs. Benzodiazepines work by enhancing a calming neurotransmitter called GABA, which slows down brain activity. Over years of use, researchers believe this chronic suppression of neural activity may speed up the kind of neurodegeneration associated with Alzheimer's disease. The brain gets used to being quieted, and the natural systems that keep it sharp begin to weaken. There's also the known problem of tolerance. Long-term benzodiazepine users often need higher and higher doses to get the same effect, which means greater brain exposure over time. France's National Health Agency conducted one of the most comprehensive studies in 2012, following over 1,400 adults for 15 years. People who started taking benzodiazepines during that period were 51% more likely to develop dementia compared to those who never used them. Across multiple independent studies in multiple countries, the pattern is consistent enough that it cannot be ignored. Medication 5. Proton pump inhibitors, PPIs. Number 5 might be the most surprising one so far, because this class of medication is seen as completely routine, practically harmless. Proton pump inhibitors, or PPIs, are among the best-selling drugs on Earth. Omeprazole, Prilosec, lansoprazole, Prevacid, esomeprazole, Nexium, and pantoprazole, Protonix, are taken daily by an estimated 15 to 30% of Americans. They reduce stomach acid and are prescribed for acid reflux, GERD, and ulcers. So how on earth could a heartburn pill affect the brain? There are two main theories. The first involves amyloid plaques, the protein clusters found in the brains of Alzheimer's patients. Laboratory research published in PLOS One found that the PPI lansoprazole actually increased beta amyloid production in brain cells. That's the wrong direction entirely. The second theory involves vitamin B12. PP is significantly reduce the stomach acid needed to absorb B12 from food. Long-term PPI use is a well-documented cause of B12 deficiency, and low B12 levels are independently connected to cognitive decline and increased dementia risk. A 2016 study published in JAMA Neurology using health insurance claims data from 73,679 patients found that regular PPI users had a 44% increased risk of developing dementia compared to non-users. Men faced a slightly higher risk than women. Not all research has confirmed this, and some studies have found no association. But for people who've been on PPIs for 5, 10, or 20 years, which is not uncommon, it's worth asking whether they still need them and whether a vitamin B12 supplement makes sense in the meantime. Medication 6. Opioid pain medications. Opioids are one of the most talked about drug crises in modern history, but their possible connection to dementia almost never comes up in that conversation. Opioid medications, morphine, hydrocodone, Norco, hydromorphone, Dilaudid, and fentanyl are prescribed for moderate to severe pain. For people with cancer, post-surgical pain, or degenerative conditions, they are genuinely necessary. But a prospective cohort study published in the Journal of the American Geriatric Society tracked older adults over several years and found that heavy, long-term opioid use was associated with a modest but statistically meaningful increase in dementia risk. The relationship is complicated by the fact that chronic pain itself, separate from any medication, appears to accelerate cognitive decline. A 2017 study in JAMA Internal Medicine found that older adults with persistent pain were significantly more likely to experience memory decline over time, even before accounting for what medications they were taking. So the risk may not come purely from the opioid itself, but from a combination of the drug's effects on brain chemistry and the underlying pain condition driving its use. Opioids bind to receptors throughout the nervous system, including the brain. Long-term activation of those receptors is thought to interfere with the brain's natural mechanisms for clearing toxic proteins and maintaining healthy neural networks. This is not a call to reject pain medication when it's genuinely needed. It's a call to use it at the lowest effective dose for the shortest appropriate time, which is how opioids should always be used. Medication 7, sleep aids, Zolpidem, and Z drugs. Here's the one that caught us off guard, and it might do the same to you. Zolpidem, Ambien, is one of the most prescribed sleep medications in the world. Millions of people take it every night. It's fast-acting, effective, and feels relatively low risk. It's not a benzodiazepine, so many people assume it carries a different safety profile, but it belongs to a class called Z drugs, which also includes Zolpidem, Sonata, and esopacolone, Lunesta. And the dementia research on this group has become increasingly difficult to dismiss. A 2015 study published in the journal Medicine found that elderly patients who used Zolpidem derivatives had a measurably increased risk of developing cognitive impairment, and some research suggests the damage may not fully reverse after stopping. A 2024 study in the Journal of Alzheimer's Disease examined sleep medication use and dementia risk across different population groups and found that regular Z drug use was consistently tied to elevated dementia risk. The suspected mechanism is similar to benzodiazepines. Z drugs also work on GABA receptors, quieting brain activity. The brain's memory consolidation systems, which depend on healthy, deep sleep, may actually be disrupted rather than supported by these drugs, even though the user feels like they're sleeping. Cognitive behavioral therapy for insomnia, known as CBTIE, has now been shown in multiple clinical trials to be more effective than sleep medication for long-term insomnia with no cognitive side effects. It's the option most sleep specialists now recommend first. Medication 8, antipsychotics. Antipsychotics are primarily prescribed for schizophrenia, bipolar disorder, and in some cases, treatment-resistant depression. But they are also widely, and concerningly, used in nursing homes and care facilities to manage behavioral symptoms in dementia patients, which adds a layer of irony to what we're about to cover. Antipsychotics, including haloperidol, Haldol, quetiapine, Seroquel, olanzapine, Zyprexa, and risperidone, Risperdal, have significant anticholinergic properties. Most of them score high on the anticholinergic cognitive burden scale. The University of Nottingham study found that anticholinergic antipsychotics were specifically linked to higher dementia risk alongside antidepressants and bladder medications. The risk was particularly pronounced in patients diagnosed with vascular dementia rather than Alzheimer's disease. In 2005, the FDA issued a black box warning, their most serious safety alert, stating that antipsychotic medications nearly doubled the risk of death in elderly patients with dementia-related behavioral problems. Despite this, off-label prescribing of antipsychotics in nursing home residents has stayed stubbornly common. For caregivers watching this, if your loved one in a memory care facility is being given an antipsychotic for behavioral management, not for schizophrenia or bipolar disorder, you have every right to ask questions. What is the specific target symptom? What's the lowest possible dose? Are non-drug behavioral approaches being tried first? Medication. 9. Antiepileptic drugs. The final medication on our list is one that most people outside the neurology world rarely think about: anti-epileptic drugs, also called anticonvulsants. Medications like carbamazepine, Tegretol, oxcarbazepine, trileptal, and some newer seizure medications are prescribed not just for epilepsy, but for nerve pain, bipolar disorder, and migraine prevention. Many older adults are on them for conditions that have nothing to do with seizures. Carbamazepine appears on multiple anticholinergic drug burden scales with a meaningful score. The University of Nottingham study found that antiepileptic drugs were among the classes showing significant associations with increased dementia risk, particularly in patients diagnosed before age 80. The concern with antiepileptics isn't just their anticholinergic properties, it's also their broader effect on how neurons fire and communicate. These drugs fundamentally alter neurotransmitter signaling, and long-term alteration of that signaling in an aging brain may contribute to the kind of neural wear and tear that precedes dementia. For people who have epilepsy, stopping antiepileptic medication carries extremely serious risks, including life-threatening seizures. This is not a category where you make changes unilaterally. Every decision here has to involve a neurologist. Almost every medication on this list, the bladder drugs, the sleep aids, the older antidepressants, the antipsychotics, shares a common thread. They were developed before researchers fully understood how profoundly repeated long-term interference with brain chemistry can accumulate. The brain is not a static organ. It's constantly reorganizing, pruning, and repairing itself. Every one of these drugs, taken daily for years, is quietly pressing a finger on the scale of that process. The University of Nottingham research found that dementia risk from anticholinergic exposure followed a clear dose-dependent pattern. The more you took and the longer you took it, the higher the risk climbed. People in the highest exposure group had a 49% elevated risk of dementia. That's not a small signal buried in statistical noise. That's a consistent, reproducible finding from studies involving hundreds of thousands of people. Here's what you can actually do with this information. Bring every single medication you take, prescriptions, over-the-counter drugs, vitamins, everything, to your next doctor's appointment. Ask whether any of them are anticholinergic. Ask if alternatives exist with a lower cognitive burden. Ask whether you still need medications you've been refilling for years without reassessment. A geriatric pharmacist or a geriatrician, a specialist in aging, can do what's called a medication review, specifically looking for drugs that may no longer be appropriate given your age and health status. Most people are surprised by what comes up. We want to hear from you. Were any of these medications on your list or on the list of someone you love? Drop it in the comments. This is exactly the kind of conversation that helps other people watching feel less alone in figuring all of this out. And if you found this video genuinely useful, not just interesting, but actually useful, subscribing is how you make sure you don't miss the next one. We put real work into getting the research right, and your support is what keeps this channel going. The sources we reference today are linked in the description below. Take care of your brain. It's the only one you've got.